everyone. I am Professor Chan Yoke and I'm the moderator for this session. I'm truly sorry to keep all of you waiting. Unfortunately, we are still waiting for Dr. Maria, who has some technical problem. So we hope to start in 5 minutes. Thank you so much. So today's topic is on HIV diagnostics, and so maybe I can say a little bit about Dr. Maria first. And basically, Dr. Maria is our clinical microbiologist, so she's currently the head of HIV and hepatitis unit in diagnostic laboratory, and she has vast experience in actually working on HIV since she actually did her MBBS program. And so actually today I see quite a number of participants. Actually, we only have one session for today. And okay, I can see Dr. Maria now, and I'm glad to see really close to 100 participants now. And maybe I can pass it to Dr. Maria now on her topic, HIV diagnostics update. Dr. Maria, over to you.
Okay, morning everybody. I'm going to give some updates that we've had at the lab regarding HIV. So in the interest of time, I'm just gonna not go through a couple of the earlier slides. It's basically just to remind ourselves what HIV is, and there's two, and that they have a homology, which is important when we're doing diagnostic testing. Okay, but at the same time, to understand that there are differences in the glycoprotein, and that is important when we're trying to differentiate between HIV-1 and HIV-2. But at the same time, they also share things like reverse transcriptase and integrase, which integrates their RNA, single-stranded RNA, and that becomes permanently integrated into the host genome. So clinically, why is it important to distinguish? Because there is a difference in the clinical outcome, and also that HIV-2, you cannot use certain drugs because they're intrinsically resistant to the NRTIs. Okay, so going right through to the test, basically, I think most everybody knows that we have 3 types of tests, which is an antibody test, and this detects the HIV immunoglobulin M or G, and this is the first second generation HIV test, and then we proceeded to have the antigen antibody combination test, which detects the HIV P24 antigen plus the IgM and IgG HIV antibodies. However, this still requires confirmatory testing. So the latest thing that we have is towards the end was nucleic acid testing, which then detects the HIV RNA. And this is actually routinely used more for viral load monitoring, and there is really not that many for the FDA, so it's US, that there's only one laboratory-based entity which is really approved. So, okay, so the initial test that we use is the old platform was enzyme immunoassay that has then graduated to become more advanced using chemiluminescent or electrocardiominescent as we use now. We also have supplemental tests, confirmatory. So for those of you who remember, we used to do particle agglutination tests, Western blot, and other tests as well. So this is what in the IA looks like when I first started. This is how we used to do in the HIV lab, and it was really it took a lot of time because it's a traditional 96-well microtiter, and there is the good thing is that there is multiple samples, but it takes time because it's still a manual thing, although there is a plate reader. Okay, So these are the generation of enzyme immunoassay tests that has occurred. So we had the first generation, second generation, which then used the recombinant HIV antigen or peptides. And then we had the third generation, which started the sandwich enzyme immunoassay. And then we have the fourth generation, which is currently all of Malaysia, as far as I know, are using the fourth generation assays where they actually detect the HIV antibodies and the P24 antigen, and they have a very high sensitivity up to nearly 100%. Okay, so this is a simple, this is actually what a capture antibody assay looks like. And I've been asked before, what is electrocommunicant? It's actually quite simple. It's basically the same thing, captures, except there is a chemical luminescence thing, which then has an electric current, and that is noted. So that is actually detected by the machine. So everything now, unlike when we first started, everything was manual. Everything is all just machine. A lot of this machine-based. Okay. So these were the tests and algorithms that we used from 2000 till about 2019. Okay, and it's basically based on a WHO strategy where you use A1, A2, A3. There's a two-step algorithm. And then if we found any discrepant, we would, from the A1, which is, we changed from third generation to fourth generation, we then did another test, and then we then proceeded to perform a third test, okay? So the first test that we did was the ECLA from the third generation to the fourth generation. We then had this thing, which was a particle agglutination test. And as you can see, this is what we do. It's manual. It's very simple. It actually has the antigens, which are recombinant P24, GP41, and GP36. The results are, because it's manual, the results are available, but it takes about 1 or 2 hours. And the good thing is that there is no electrical equipment required, and it's an inexpensive test. And it is widely used throughout Asia, South America. So the problem is that because it's manual, sometimes there are issues that we have to repeat it. And then there's also, as you can see, this is actually how you have to interpret it. And it's not that easy. It needs some sort of expertise. It is pretty labor intensive. Now, these tests are actually still being used by KKM. As of yesterday, I checked. They still have it in the algorithm. We don't anymore. Okay. We also then used, as part of our testing, a second or third antibody test. Example, earlier, HIV 1-2 combo. This only detected antibodies. So the disadvantage was that it was useful as another test to help, but because it didn't have P24, so therefore it can only detect antibodies. It also required manual reading, but it was quite easy because it's basically an ICT test. Okay, if at any point then we had further discrepancy after we've done those tests, then we went into a line immunoassay. Okay, and this is an example of what we would have got. There was, I remember doing this, and there was a lot of issues with this because, first of all, it took time for us to do it. It's a very cumbersome test. And there are different criteria for the interpretation of the HIV Western blots. The good thing is that it actually can detect the glycoproteins of HIV too. And it actually has P24. But as I said, it's a very cumbersome procedure. We actually had to wrap it up in aluminum foil, and it was light sensitive. And because it was stripped, we had to align it, and it was really difficult to read. We ended up having a reader, and the reader was better. But the turnaround time, we had a lot of issues when there was problems which were indeterminate, and our turnaround time at that point was 1 week. So There is also no FDA-approved HIV-2 Western blot, although we could somewhat say, but we couldn't use it for HIV-2 diagnostics. Yeah, okay. So although it's still uncommon in US and here, as I mentioned, it doesn't respond to NRTIs and some PIs. And we can't see it because we've only got HIV-1 viral load. And they have actually, this is from the CDC, they have been misclassified by the HIV-1 Western blot. That's why they did not approve any of the 9 immunoassays or Western blot to actually detect HIV-2. Okay, so just very quickly to remind ourselves about the serology profile of the HIV, because it actually determines our diagnostic algorithm as such. So when you have the HIV infection, there is actually an eclipse period of about 10 days when you can't detect even with your viral RNA. So this is your HIV RNA, and your P24 actually is around 15 days, which is now what the viral detection, the 4th generation immunoassay can detect. And the HIV antibody, which are the old ones, is about 25 days. It's the 3rd generation. This is the 2nd generation, and this was the 1st generation. So you can see that in terms of HIV diagnostics, it has really moved very far down towards here, when you can say up to around 10 days for the HIV RNA. So we were using that algorithm until it was noted that, you know, like in 2014 there were new algorithms put up by the CDC precisely because of all the problems that I mentioned, and this was further updated in 2018. However, we did not move to it so quickly because there was some talk with KKM and all, and in the end we decided to go on ahead and test those different platforms so that we would be abreast with what were the recent guidelines at that time. So this is actually the guideline that was given by CDC, where if you do a HIV-1/2 antigen antibody immunoassay, and if it was positive, the confirmation test that was recommended was actually a HIV-1, HIV-2 antibody differentiation immunoassay. And if it was negative, you could, depending on the clinical status of the patient, you could ask for a repeat test in 2-3 weeks' time, in case you fell into the eclipse period. So there were a few possible permutations that can happen. HIV-1, HIV-1 positive, and such. And you can even have where both of them are detected. I'll talk about that in a little while. So if it was indeterminate, the recommendation was to go to a HIV-1 NAT test to differentiate, to confirm which way it was going. So just to note, we do not have a HIV-2 RNA test as such. Okay. So in the end, we actually ended up with this as our diagnostic HIV test algorithm. So we would have, if it was reactive, we would repeat in duplicate, and if it was negative, we would say negative, and then depending on the clinical picture. And then we will go into the HIV antibody differentiation immunoassay, and that would be the algorithm that will follow as such. So this is our current SOP. So the new algorithm includes 3 tests, which is A1, A2, A3, we put as such. And it uses, it doesn't use any more Western blot because of the issues that we had, and it addresses the need to detect and differentiate HIV-2 from HIV-1. Okay, so we actually remember looking at this at the multi-spot, and it had some, but unfortunately it was withdrawn. I'm not quite sure why, still don't know. The results were actually quite good, but maybe it's a manufacturer issue. In the end, we actually looked into this particular assay, which is called Genius, HIV-1, HIV-2. And it's a very, very, very cute design, and it's very, very efficient. I'll talk about the NOA. So in the beginning, sorry, this is the combi-PTS. Let me just carry on first. So the current A2 test is the antigen antibody HIV-2, HIV-1 differentiation immunoassay. It is FDA approved, and we went down that pathway because we looked into validated papers. It was actually quite brave or something. We had Prof. Yasmin to help us with it, because when I talked to the KKN people, they were very reluctant to do this because nobody had done it. But we decided to validate it for ourselves. We evaluated it, and we actually been very happy with it. It's a simple immunochromatographic test, and the good thing about it is that it is an automated reading, so there is no error as such, and it actually can give, as mentioned, separate results for the HIV-1 and HIV-2 antibodies. Okay, the principle is actually quite simple. There's an antibody binding protein which is conjugated to gold dipeptides. It's a very standard ICT, and the anti-HIV antibodies are then captured by the antigens which are immobilized in the test areas. There's a lot of bands, band 1 to 6, and if there's no antibodies, there are no lines. So just to show, this is how it looks like. The thing is, you can use serum, plasma, you can even use whole blood for this specimen, for this test. If you use venous blood, specimens can be tested and can be used later, and you can even use serum and plasma specimens that are frozen. Okay. Okay. So this is actually how it looks like. It is actually a very small footprint, and it doesn't take much. It's in the past we had one whole lab for HIV, and it was actually quite a scary place to go in, and it was all. So now it's just a very simple. It takes about less than half a bench, like that. So it's really small, and this is the reader, such. So it doesn't. It's a very nice footprint, and it's fast. It's done, within 30 minutes or so. You get this is actually how it looks like as it comes out. So we had the choice of reading manually or using something which is a reader. We opted for this because there will be no errors as such. So it's actually quite it's actually been simplified a lot, that we don't have to worry like for the particle agglutination to read such, and the Western blot. There was just so much difficulty with it. So this is actually how it looks like, and with each band it actually represents different envelope peptides, and the earlier diagram that I showed that would represent HIV-2 and HIV-1 as such, and there is a control band. Okay, the interpretation criteria is also laid out very clearly for us. So if they have this, and in fact, this is in the insert, but we use it as kind of a reference, because when we get the results, it actually comes as a piece of paper and actually tells everything. And for us to validate, there are the GP there, glycoprotein results there in case you want to refer. So these are the HIV-2 criteria. For HIV-2, it must be present GP36 and GP140. So there is the matrix protein has to be there. And obviously, if there's no band, it's negative. And it is indeterminate if there is only one envelope, either those or a GP140 band. HIV-2 has 140 instead of 120 as HIV-1. So the assay also gives us how to interpret if we have results such as this. And we don't really, generally speaking, we don't really get, when we first started the assay, we were quite worried that we would get lots and lots of difficult cases. But we actually, most of the time, it's pretty straightforward. We do the enzyme immunoassay and we then confirm it using the Genius. So the way we run our test is that even if the patient has had a HIV test outside, if the patient is new to UMMC, we will still consider that person as a new patient. And if it's positive, then we will inform the doctor. We will also note in our lab information system, and they have to send a repeat sample. Okay. So there are limitations. So it's not 100% perfect. There are times when we get the indeterminate profile. As I mentioned, it's not very often. And the reasons that it can be is possible unlikely cross-reaction with other retrovirus. There is a cross-reactivity, and in this kind of cases, when we are not sure what we do, we've had one recently. I've had one recently, late February. We're still waiting for what we tend to do is we will call the clinicians and we ask what is the history, and we actually ask for another sample, and we go down, we do a HIV RNA. Okay. So if you have, so what happens if you have some unusual ones which are untypable, where there are all 4 envelope bands detected? So that means all of the HIV-1 envelope and all of the HIV-2, and that can be visualized. So we have not had that. So there could be a possibility of HIV-1 and HIV-2 co-infection. And samples which meet both HIV and HIV-2 positive criteria are very rare. And obviously we have to confirm further. So these are some of the assays, these are some of the papers that were done to evaluate the assay, and it had a very high sensitivity and specificity as compared to the Inolai assay, which is the Western blot line immunoassay that we were using. And it reduced the number of indeterminate results and shortened the overall turnaround time. So for our colleagues out there, they would know that last time there was a lot of issues, and our staff had to go back and forth the samples and repeat. So now most of the tests are pretty straightforward. Yes, we still have problems with indeterminates. We'll talk about that in a little while. So these are some of our reasons, and when we looked at the literature, we were happy to choose the Genius assay. As I mentioned, we were actually looking at another assay, but that assay was somehow discontinued by FDA. So this is our own evaluation that we did, and we had a correlation. So we felt comfortable to go on ahead with this test, which we started at the end of 2019, November 2019. So one of the reasons why I am also updating the faculties that many people didn't maybe not aware that we changed, and some people have done studies or whatnot, and there is a difference that of platform that you'd have to consider if you are going to do your studies such. And this is actually what's been given by CDC. If you were to follow the differentiation assay route, and what will be the final algorithm interpretation. And this further action is not for us, but for the ID physicians or the clinician in charge to think of the possible further actions that should be taken. So from something that was very difficult, very fuzzy, you know, kept asking if we were to repeat it. There were times, this has truly happened, that the line immunoassay, the strips were misaligned. And I remember, you know, like being quite frustrated about it. So the test has actually made our life a lot easier and faster turnaround time, which is good for the patients. Okay, so the other thing which was good as well is that we also did some evaluation where we actually we have a cost reduction because if we had an unresolved case where we had to do a rapid PA, inhaler negative HIV RNA, this would be the, you know, we would actually spend, okay, these are quite old figures. The HIV RNA has reduced a lot, but still it would have taken multiple tests for us to confirm. So, and also, as I mentioned, if there were issues, it might take about a week for us to try and get something tangible. So the HIV RNA, I think now is about 100. I think I'm not 100% sure, but it's even reduced now from this price. Okay, so the new SOP has a TAT for screening as early as 4 hours, and we sort of say maximum 24 hours. So if you send your sample early, we can do it really quickly. And the old SOP for the screening is about 3 hours due to batching. And if it was indeterminate, we have to confirm, and first we do the line immunoassay and as such, and so in the end we end up with RNA. So it can be stretching up to 10 working days, and the cost is a lot on the patient. Okay, so what are the challenges regarding the new algorithm as such? So the HIV viral load RNA will probably play an increasingly important role in diagnosis. So what we have for the quantitative test is actually meant to be for monitoring, but as of yesterday, I updated that what tests that we have, they're actually in their insert. It is they can use it for confirmation. So it is something. So we are still having the A1, A2, A3 pathway. When we have indeterminate or discrepant results, we have difficulty because there is no real HIV2 testing. So we have used before NAT, the blood bank NAT test that we do, because it also does HIV2. We can sequence. We also can go to refer to IRMA, where they have a platform. There is a new Abbott test, I'll try and put it out later, where it is an RDT, and the previous RDT Abbott had bought over Allaire, so we were using Allaire, but Allaire at that point, or Abbott, did not have the P24. So now the new Abbott RDT, they are trying to, it's of this year, I think, they're trying to sell it as a possible help if there is difficulty when you have indeterminate tests, because you know, it has P24, so we haven't actually looked into it. So this is some new discussion that I was talking to Abbott about. Antibodies may also fail to develop or may decline when ART is initiated during acute HIV infection. And now with PrEP, there could be antibody attenuated response. The last one I put in because I wasn't 100% sure what the viewing security level of the clinicians, whether there is any issues and who can see the results. And we had some recent cases where I wasn't quite sure who actually saw the results. So I think maybe this is something that may have to be discussed with clinicians who are involved actively in HIV testing. Okay, so this is the Abbott test that I've been to a recent symposium, so they were kind of trying to sell this. So it's no more second or third generation. It's a fourth generation test where they believe that it could possibly help. So they are actually quite keen to give some kits and see how well it does with regard to Genius. They send some articles that shows that it has got a high, they put up 97% sensitivity and 100% specificity, but obviously, you know, we would have to do our own evaluation. So unlike the previous one where we did not have the P24, this RDT is it has the P24 and should in theory be able to detect the early infections. Okay, so CDC says that, and CDC is very clear on going to the antibody HIV1, HIV2 differentiation pathway. However, WHO has not gone down that pathway as such. They still kind of, so when we were trying to figure out algorithm, I remember having a discussion whether, because this is 2019, they still say A1, A2, as such, A3. So we also said that we also had an A3, so that's how we sort of like comply also to WHO, the fact that we have the HIV RNA. And as of yesterday, I did check with KKM. So far as I understand, I'm not sure, I'm sorry if I'm wrong, but as far as I know from KKM friends, is that they still are not, they're still going down the pathway where they do, they're mainly more Abbott centered for the KKM, and they're doing a 4th generation assay, and they still are doing a particle agglutination test. So the thing about the enzyme immunoassay test, so there was some slides, sorry. It actually now there is, I said 4th generation, there is now something which is called an advanced 4th generation, whereby you can actually distinguish the antigen from the antibody. So this is something, again, this is it's not exactly new. We have actually moved from the Roche platform to the 801. So we have actually moved that around 2021, around that time. But so the first EIA test that you will see, actually we can tell you if it is P24 you're detecting or whether it's antibody. At the moment, the machine does it. It calculates and gives you an average, and it actually tells you about the cutoff index, and it actually calls it reactive as such. But it is possible to actually see separately. And I was told that people in Penang were using it, and that they were actually showing it in the results, and then they had a different algorithm. And if it was antigen positive, they would then go down the PCR pathway and confirm. If it's not, then they would then go down another enzyme, the PA, whatever they're doing. So it so happened that this person was actually a student of ours in MPAS, so I actually rang her yesterday to discuss, and she said, no, that's not true, because KKM hasn't actually given a guideline on that. So what they do is that if the clinicians are concerned about cross-reaction, someone, dialysis patient, someone with autoimmune loss of antibodies, so they want to make sure, then they actually, an early infection that they're worried, then they actually ring and ask for the antigen with what it is. So at the moment, we're actually hiding it, but it can be open to discussion. I think I had a chat with Prof. Iskandar yesterday about this. So this is something that maybe many people are not aware. So with WHO, they are more, not sure whether the word conservative, I think it's because of the fact that I think it's a resource issue, although gene is actually not very expensive. I think to me, it takes a lot of burden and time and it's very efficient. But this is still 2019. Sorry, this is 2021, where they actually still recommend this, and they have this thing about high burden and low burden countries where they are very, they strongly urge. So we are, what I understand, low burden, less than 5%, and we need to have 3 consecutive reactive tests for an accurate HIV diagnosis. So they did not mention differentiation tests. So we consider ourselves as doing one anyway. But they also have updated that the line immunoassay, so that's good. So they also said that Western blot and everything shouldn't be used because of the inaccuracies and the difficulties and the turnaround time. So unfortunately, there is another. I was actually hoping that they would come up with this, but as of yesterday, there is no, if you open the WHO site, they haven't actually given any updates. So, but from the little that I read online and everything, there is a lot of move towards using RDTs. There's a lot of move decentralizing the HIV. So that would be an interesting thing to think for us, having a referral lab. So I'm sure we won't lose our jobs, but I think that it's something that we have to think in the future on outreach to the community, and also for people with PrEP, as mentioned. Okay, I think my time is up, is it? So this is what we moved from the 601 to 801. So it's really efficient. There's, trying to test. I'm going to go on because I can see my head looking at me there. So this is the this is the 801. It's called the HIV Duo because of the fact that you can actually do this separation. So it was called 5th generation, but they decided not to call it 5th generation for some unknown reason. They're calling it advanced 4th generation. I have no idea why. So this is what they kind of suggest can be our algorithm. Again, this is not what we're doing. This is just a suggestion from them that we will see if anybody. It is very fast, and they said that so this is the technicalities. I have no time to go through as how they actually do the physical separation of the antigen and antibody. If anybody's interested, I can of course give this slide. So this is it. Okay, so I'm just going to go to the summary points. Yeah. So laboratory markers of HIV infection, HIV RNA, P24, IgM, IgG appear in a consistent sequence and are the basis for all HIV diagnostic tests. In order to not get confused, you need to know the serological profile, as in where, and many people forget that there is the eclipse time. I also would probably like to say here is that all this go by the clinical. It's very important to always look at the patient and ask all the clinical details as such. So an ideal screening test should be sensitive, specific, and limited to conditions for where there is available effective treatment that can directly target the disease and improve prognosis and outcomes. And to note that HIV-2 has a different treatment management option. On saying that, we've had a few cases that I understand that there was one case, but that person is not Malaysian. So we have, but we do know, someone says, how do you know that you can actually test HIV-2? So for those of you who are unaware, we actually have a quality control where we test, we were given samples we don't know. So we do know that we can detect HIV-2 from our RCPA quality samples that are given to us. False negative HIV screening tests can occur during acute HIV. And this is where these new tests are trying to sort out the false negative and false positive during the early sessions. So false positive HIV screening test results may occur due to cross-reactivity with other antibodies and hopefully not, but possible lab errors. And testing for HIV RNA may identify early HIV infection, but remember there is an eclipse period, and but they are positive a week sooner than antigen antibody test. So if you're thinking what test to do or what, but HIV RNA is not generally used for screening because some I have had people ask, why don't you just do HIV RNA? Because obviously there is cost and it's not as easy as doing the other tests, the ELISA such. And in 2018, 2014, the CDC did give a new HIV diagnostic testing guidelines, which incorporated the HIV-1, HIV-2 differentiation assay, and testing for HIV RNA to be done where the initial test is reactive, but the differentiation assay is either non-reactive or indeterminate. Compared to the previous algorithms, this current algorithm is likely to detect acute HIV-1 and more accurately diagnose. HIV-2 allows for faster turnaround time and leads to fewer indeterminate results as compared to previously. Because I know people are going to go back and say, oh, but we still have indeterminate results. As I mentioned, it's not 100%, but the number of indeterminate results are much less than last time. And remember, the turnaround time is so much shorter. Single-use point-of-care HIV tests and in-home tests are additional options to help HIV screening and detection. And this is something that we think that will be seen in the latest WHO guidelines. A reactive result on a point-of-care or home test should be considered as a presumptive positive and requires further tests. I don't have time to go through that. And the confirmation of HIV-2 infection can be challenging since HIV RNA assays do not reliably detect or quantitate HIV-2. Challenges can still occur with the diagnostic evaluation of indeterminate results, acute HIV very early, infants and children exposed to HIV, and persons receiving PrEP.
Maria, maybe shall I just go to the question because we
sure. Okay, we'll do it.
Okay, maybe we can just end this with 4 questions. 2 from Dr. T and 2 from Dr. Iskandar. Okay.
I was thinking one.
Yeah. So Dr. T asked about any HIV-2 patients detected in UMMC or Malaysia to date.
Okay. Right. So
can you give short answers because we have to finish.
Oh, okay. All right. Fine.
Yes,
fine.
No. Percentage. Yes. No.
Oh, okay. So we've had cases, but no locals. I don't know whether to say this.
Imported case. We can.
Yeah, I don't know whether to say this. I'm still hoping that it will be like that sounds bad, but it would be exciting if there was, but not so good because that would mean that we have HIV-2 around, which may go around, and we wouldn't want that. So in a way, it's good for our population.
Next question.
HIV-1.
The current testing algorithm. What is the current testing? It's the current testing algorithm for adults similar to newborn. It's HIV and mother.
Newborns is a bit different. This is something that I think I would have to put it. I'm actually giving a lecture this afternoon for those interested for the medical students. Maybe we can cover that. So it's a bit different because we can't do antibody testing up to 6 months because they would have it, for the maternal. So those are issues that we'd have to do. So again, this is where molecular testing, HIV RNA would be useful for viral DNA for children, for neonates. Okay.
So it'll be different.
Infants.
Okay.
Yeah. Okay. So I was talking, just to clarify, I was talking about more than 18 months just now. So adult to after 18 months. That was the test, the algorithm. Okay. Next.
So that means the answer is different. Okay. So third question. Can you by Dr. Iskandar, can you discuss the optical density value of HIV antigen antibody test and the clinical utility of reporting it when it's indeterminate or discrepant tests?
Okay, so what happens is actually I didn't say the full SOP where we actually would repeat in duplicates. So when we actually tell you that it's usually 1. So from the experience that I have, whenever you have like 1.24, whatever like that, usually when you repeat it again, it would then be negative, especially if you ask the patient. So I've had a case where we asked, And remember, the patient was having a cold or something, or some influenza. So those are things that might give you that indeterminate, that's sort of like 1.1 or something like that. Yeah, so there is a cross reaction. So the fourth generation assays are extremely sensitive, very sensitive, maybe in a way oversensitive. That's where maybe we can have a discussion about, is there a use for the so-called fifth or advanced fourth generation? I think we had a little chat yesterday, Prof. Iskandar, before you had to go for your dinner. So maybe this is something that we can discuss further, and yeah, how we can improve the diagnosis.
So the last question from Prof. Iskandar as well. Do you have recent assays to detect risk? Do you have recent assays to detect recent infection as part of HIV surveillance?
When you mean by recent, I mean, we still don't have any that can detect that 10-day eclipse period. Okay, so what we have right now is exactly the serological profile that I showed you. And we should be able to detect if there is a need. Obviously, we don't start with RNA. So if there is a real need, then it can be discussed, but it's up to 15 days, about like 2 weeks. That's what we would expect. Maybe even 12 days for the EC-line to be positive. Yeah. So again, it's always best if there are issues to discuss, so that we know, because then we can determine which way we're going. Yeah. We are on call 24 hours, so you can always call and discuss your issues. Yeah. But we do not have anything. If you're asking for the 10 days, I don't think we can hand on heart say that we can detect it. Okay.
Okay, thank you, Dr. Maria. So in view of time, is already 9:04. We want
apologize. Couldn't get
Maria. In. Yeah. Sorry everyone that there's a delay in this talk, and thank you everyone for attending. Have a nice.
Thank you everyone.